once a month. This is our third Friday meeting. Today is the 20th of March. Our next third Friday meeting will be in April. The third Friday in April is one, two, three, the 15th, I believe. And then we also have a Tuesday meeting coming up, the first or the second Tuesday in in April, Mike. And we've got for that meeting, we have our national legislative leader coming in with us, Carrie Reingans of Michigan. She's running the single payer bill up in Michigan, Carrie Reingans. So she's going to be with us on Tuesday, the 14th at 5 Pacific, 8 Eastern time. So make a note of that if you would. So Edwuan is going to be speaking with us today about really the 50 state strategy, about putting together a model bill for all the states that don't yet have a bill or want to improve on the bill that they have at the state level. And then we'll have some conversation about the legislative portion of the strategy, right, to get us over the top in order to model universal healthcare systems in any number of states. We have 18 states that are running single payer or approximate single payer bills. We want to get up to 50, and Edwuan's going to share his thoughts on what that looks like and how we can get there and what you can do to make this a reality so we can get this bill passed ASAP. So with that, let's put Edwuan on the spotlight, Mike, and welcome. And
Not
welcome
the
everyone to the
spotlight.
meeting.
Jeez.
You're awesome, Edwin. Edwin,
So
thank you.
I appreciate you, Chuck. Thank you guys. I'm glad everyone is here today. I have been and I will say we have been working very diligently through trying to see what we could actually do with this bill. I have been running around just trying to think of ways to make whatever dreams people have a reality when it comes to this legislative notion. Um, and so for me, I think the biggest thing is we continue to kind of walk through and kind of see what state-based healthcare legislation looks like. We're trying to make sure we're challenging folks to look at the big picture, and then think of it from a grander scale, right? So for me, with this bill particularly, if we're able to figure out what this bill looks like, right? Um, because we have to remember something. Between states and the federal government, the states themselves have to balance their budgets every year, right? That's mandatory. That is a mandatory part of the process. Um, and whereas with the federal government, obviously they don't have to, they don't give a damn about balancing a budget. They'll go into trillions of dollars of debt whenever they feel like it's necessary to do so. And so in that regard, we have to be very forthright and thinking if any state was to pick this thing up and find the way to actually mitigate balancing their budget and ensuring that all of the people within the confines of their borders actually have health care, the federal government no longer has an excuse to say, "Oh, well, we can't do Medicare for all," because now that's a complete BS situation altogether. Because you as the entity that can go into debt, right, and into the trillions, you can go into as much debt as you like. How are you going to come tell the state that's got to balance their budget, and we making sure all our people got health care? What's your excuse for telling me that you can't help the nation do that, right? And so even in that vein, it also allows states to take their power back, right? Because we know relying on the federal government, especially with this current administration, is not the best thing in the world. Um, and so for me, as being a Virginian, and being right at Washington, D.C.'s back door is very, very helpful for me and in my heart and my mind, to ensure that, well, if D.C. can't do it, well, Virginia gonna give it one hell of a try. And so when I met with Chuck and we started having, and especially with Steve Kimball and Mike, we started really having deep conversations about what healthcare looks like overall. What have been the struggles over the last 10 years of trying to work through this thing? Some of the regrets that we've had just on face value of the ACA, and while it did help navigate a lot of folks to retrieve actual healthcare and healthcare insurance itself. We do know that in that process, we had to give insurance companies a whole lot of leeway. We had to give them a whole lot of incentives. And so within that, it kind of just boggled us back down to the 1970s way of doing things, which is allowing insurance companies to kind of run amok and try and profit off of us as much as seemingly possible. Um, and so in that vein, there is always a way that is better. Um, we just have to we have to fight for it and face it. And it's usually fight for it on the people's side, and then for the legislators, you got to face it. Um, and so for me, I did come up with a bill for Virginia specifically, which I will actually pull up and show all of you here in a second. Um, it is called the Cardinal Care for All Act, because in Virginia, the Medicaid program here is called Cardinal Care. And so it would just be taking an expansion of that name and then making it the overall Medicaid for All kind of Virginia version, right? If I was in California, it'd be CalCare for All, So just kind of thinking it in that vein, okay? I think if I was in Wisconsin, it would be Apple, uh, which is better than the Apple Care for my phone, I'm sure. Um, but let me go ahead and pull this bill up. Any questions, comments, concerns for me before we jump in? I definitely want to give a big shout out to Steve Kimball before I jump in. Because when I tell you that man was my guidance, that man was my guidance, okay? A lot of sleepless nights, a lot of sleepless nights working with him and getting his feedback and things like that because he's just it's all in here. So I do want to pass it to Malia. I saw your hands up.
Yeah, would you mind giving a little intro since I don't know you?
Oh, sure, Malia. I didn't
Thank
see
you.
your thing in the chat. I'm sorry about that. So I'm Edwuan Whitehead. I'm the public policy director for the Center for Common Ground. I have been since December of last year. Um, I just finished my first General Assembly session in Virginia. What was that, March the 16th? So we just had St. I. We'll be bouncing back for the budget season, but um, some victories in Virginia this go around, which I'm thankful for. We got to raise the minimum wage. We got paid family sick leave on the books for folks in the Commonwealth of Virginia. We expanded unemployment benefits. We've expanded SNAP benefits. You know, I it it's and I wish I honestly just going through this session, I really, really wish that um a lot of states could start, especially in the South, could really try and utilize Virginia as its template. I know our numbers look really, really good right now because the way our political climate is kind of set up. And it's taking advantage of those moments when you have them. And so that's something that we've been doing to try and nail down some of these things we've been trying to nail down forever. Raising the minimum wage to $15 to $20, right? Been wanting that forever. Getting paid family sick leave, been wanting that forever. We still trying to figure out how to pay for it. We got a whole budget fight about that next week. And so wanting to see those kind of things get duplicated across other states. And Center for Common Ground does cover, let me see how many states we've got: Virginia, North Carolina, South Carolina, Georgia, and Alabama right now. We do have many democracy centers in New York. We have some traction in Wisconsin. And so for me, it's what can we do to make people's lives the most dignified that we could possibly make it from birth to death, and what can we do to always improve the quality of their life?
Virginia
And this
has
is
made so much progress since I left
yes,
there in 2010. What a difference.
yeah, we're
Yeah,
running,
yes,
sprints.
yes. And in the positive way too.
Oh yeah, absolutely, absolutely, absolutely. And I'm honestly, I want us to be the template for every single solitary state, in that regard, regardless of what strides we choose to end up making as a state, that other states can implement the same thing and to show you that it's not impossible, right? Like once we get family sick leave done, I don't see a reason why there shouldn't be every single solitary state should be like, well, let's start looking at what this looks like. How much is it going to cost to actually pay for it? So those that's just kind of the mindset and the philosophy of my background. Um, as a Black community organizer and community as well for a very long time, since 2014, 2015. we've been running and working years for these kind of moments. And so that's not lost on me. Someone said something about corporate power dominates legislative support. You're right. That's why I put up a bill this year that was the Corporate Reset Power Act bill, which they killed. I'm upset about it. Because we have a tendency to forget, or at least a lot of the time legislators do anyway, that between you as a legislature and the SEC, if you've got one, the State Corporate Commission, you regulate corporations in your states. You tell them what to do. You tell them what not to do. And they have to succumb to that. And so when they're using their power and their influence for things like that, you gotta find one good legislator that's gonna whoop them right back in the shit. Like, at least put the conversation on the table. I'll make 2 points on that, and then I'll move us. Okay. There's a House Bill 1447 by Delegate Jackie Glass in Virginia. It's the Corporate Reset Power Act bill, and it is literally just a reset of the rules. It's to say, hey, I don't know if you forgot, but we run this and this is what the list of rules are, and this is what the list of rules are not. Okay. And then the other thing within that too was that we put forth legislation with Senator Danica Rome around campaign finance. We were asking specifically utility company Dominion Energy in Virginia that any money that you get from ratepayers, please don't use it for your political movement, and please don't use it for your marketing, because I don't want to spend my money that I give you on that. I never want to spend the money that I give you on that, actually. And better yet, I'll do you one even better. How about all the money that I ever give you, you only spend on the infrastructure for my lights to stay on and finding ways to keep my damn lights on when it's cold outside? Let's do that. Let's not keep worrying about the data centers and what you want to do politically and how you want to maintain your profit margin and all that. I'm not worried about that. You're going to make your profit regardless. And so some of those kind of counterbalancing acts are ways to fight some of these corporations from the legislative perspective. You just got to be willing to find one that's willing to fight. That's all. We've got a couple that are willing to fight. And so that's been the fight. I'll jump us and move us here. Let me grab my screen. So I've got all of the. Let's see.
Wait, Mike, you made Edwuan co-host, right?
Yes,
Yeah.
he did. I'm sharing my screen right now.
All right, cool.
So forgive my 2,000 tabs. Don't wait out on me. Let's see. So I've got that one. Let's see if I have it. Where is it? Oh, that's gonna be in my. It's on the ground. Stop share. Okay. So I know the AI Gemini is kind of telling on me what's in here, but that's all right. So I've got 3 documents in here in this folder. We worked through I worked through a template of sorts, which in hindsight, just thinking of in that regard, as I was working through this giant omnibus bill, I came to the conclusion that when we're talking about doing this on a state level, we have to be expeditiously and extremely mindful of where particular states are in their healthcare fight, right? And so because of that context, particularly because each state is different, each state is in a different disposition. Like where Virginia is right now is what I would say is the ultimate place to be to have Sabuka happen right now. If I was to put this in front of the General Assembly with the fiscal impacts, I could pick this up in 2027 and try and get it to get done with all the fiscal parameters and everything. In other states, that's not going to be the case. I've looked at other states already, like Georgia, South Carolina, Louisiana, Mississippi. There's a lot of states right now that are not anywhere near close to the position of where Virginia is from a healthcare perspective. To be able to run as far as forward is to move into a state-based universal healthcare system without having to completely not only rethink of the way that they do healthcare altogether, but to literally, in some regards, like completely tear it down and build it back up with all of the punishment that would come with that. And I'm like all the blowback that would come with that, with pausing benefits or trying to move into a stepping stone system. So things like that, even in that regard, it would be a lot more difficult for some states to be able to facilitate like picking this up right now. And those are the facts. I see Lode is in here. Lode is one of my partners in crime from Center for Common Ground. She's over in Georgia. She know firsthand, Pathways ain't doing nothing for nobody in Georgia but making them sick. There's only 9,000 people on that entire program for the entire state. And I will tell you, folks, Georgia is a damn big state. And so when we're talking about those being the comparisons of where certain states are, we have to be expeditiously mindful and very, very careful and very willful and intentional, as I always say, around the unintended consequences that could come along with doing this for certain states if they're not on that pathway or on the right pathway to get it done right away. And so with this process, it may look like sometimes it could be up to a 5-year process for folks to really get themselves in that disposition. And so I do want to start with just an overview outline of the bill itself, and then we can jump into the policy part of it. So the overview outline bill really just kind of comes to your legislators and kind of gives them I wouldn't necessarily say like a 1-pager, but like a good little 5-pager on how and what what the goal is for what I would call Medicaid for all, right? Which for Virginia would be Medicare for all or Cardinal Care for all.
Edwin, can you expand that so we can see the print better?
Oh yeah, absolutely. Let me see if I can zoom in on it here. Zoom in. Is that better?
Not yet. Click on it. There. That's getting better. There could be more. Like 200. That helps. Thanks.
So, yeah. I'm sure everybody can see this now. Fantastic. So this is the kind of the overall outline bill. So for me, this is step 1. This is where you come to your legislators and say, hey, I know we're doing all this great stuff with Medicaid and all that fun stuff, but hear me out. I think we should cover everyone in our borders with healthcare. Kids, regardless of the socioeconomic class, adults, disabled folks, trans folks, gay folks, Black folks, white folks, yellow folks, who cares? Everybody. If you're a Virginian, they getting covered. I don't give a damn how we do it. We got to cover them. And so I kind of went through the legislative findings and intent. And this was purely based off of studies that our General Assembly in Virginia has already done. Like literally, they've been looking at this stuff already. And so in that, we get into the findings. That healthcare, of course, in the Commonwealth of Virginia faces rising costs, which is everywhere, of course, workforce shortages and increasing administrative fragmentation, placing families, providers, and local governments under growing strain. Despite the expansions of Medicaid and availability of qualified health plans on the federal marketplace, hundreds of thousands of Virginians still remain uninsured or underinsured, often avoiding necessary care due to costs. We know that the linkage between health insurance and employment restricts worker mobility and suppresses entrepreneurship across the Commonwealth. Even though Virginia has a multi-payer system dominated by a lot of like complex billing and rising premiums and a lot of high overhead costs, we know where that waste is and what we want to try and do to help navigate it. And so that for me is where, that's why I want to go with the overview outline bill first, because you really want to lay it out. You want to lay it out to your legislators and be like, look, this is where we are. This is what we're trying to do. this is what the fiscal impact of this thing is going to look like. And that honestly, that universal access right now is the most, pivotal thing that we could possibly have to make sure that everybody gets all of the services that they need without having to go through the strain and hassle. And it's going to cost the state a whole lot less in the long run.
Could you expand it just a bit more,
Yeah.
Edwin? Yeah, there. That helps. Thanks.
Yep. So then it brings forth the actual creation of the program itself. And so hereby created the Cardinal Care for All Act, which is a publicly financed covered program that is administered by all of these departmental organizations within Virginia that actually cover health in some way, shape, form, or fashion. So in Virginia, we've got the Department of Medical Assistance Services, we've got the Department of Health, we've got the Department of Health Professions. We've also got the Department of Behavioral Health and mental instability. We've got so many of those kind of departmental agencies just kind of spread out throughout Virginia. And so the goal is to take all of those entities and then bring them into one. Right? Bring them into one solid thing. And so within that, we have to make sure that the main three things that we're thinking about here in the creation of this kind of program is that you don't want folks to not lose the care that they already have. You want to bolster that. You want to make sure that whatever they don't got, they got it. Okay. And so 3 simple rules: comprehensive and medically necessary healthcare services for all Virginia residents, continuity of care without discrimination based on income, age, disability, immigration status, or pre-existing conditions, and coverage that supplements the federal programs that already exist, like Medicare, TRICARE, Virginia, the VA Health, which is Veteran Affairs Care for folks here in Virginia, and sometimes the employees who actually work for the state, and federal employee health benefits without disrupting them at all. Those are the 3 simple principles that we've got to be focused on, especially number 2. That's the biggest one for me. We just had that discussion with someone yesterday. Like literally, they were like, well, folks are going to get discriminated against. I was like, listen, if you look at my bill, any of them, one of the main components is always and forever and shall always and forever be no discrimination for healthcare. It's a human right. Go ahead, Barb.
Would undocumented immigrants have health coverage?
Immigration status is there. So yes,
undocumented, everybody.
I don't care what your immigration status is. I don't care what your disability is. I don't care what your income is. I don't care how old you are. I don't care what pre-existing conditions you got. If you are a member or a resident of this Commonwealth, you got to get that from me, baby. You got to get it. I'm sorry. I love you. I mean it. You got to get the healthcare.
If you go out of the state at any time, would you still be covered as long as you're a resident, you're a citizen of the state?
So yeah, in the big omnibus bill, we kind of go into that, right? So when it comes to out-of-state billing, what you like is the simple DMAS rule that we have right now. So in Virginia, what DMAS does is they back bill for up to 3 months of any medical services that you've had. Okay, and so what that looks like is if Edwuan isn't covered right now, right, and then I get Medicaid starting on the 1st of next month, anything that I've done prior in the last 3 months for when I went to the dentist or if I went to the hospital or emergency room visit or what have you, DMAS, if I let DMAS know and call them, they will go back and back bill for those things and actually cover it. Mm-hmm. And so it's the same concept. If you go out of the state, you get any services done in another state, get whatever financial records you need to do that, bring it back to your state, let them know, hey, I was out of the state when I did this, so what have you, can I be covered?
Mm-hmm. Edwuan, I'm just gonna jump in here just so that we have the process clear in terms of questions. Do you want to get through your presentation, or do you mind people stepping in with questions as you're going along?
I don't mind. Either way is fine with me. Honestly, I'm happy to keep rolling us through.
Okay.
And then, I mean, I know we've got time for the outline bill, and then I'll kind of give us a brief overview of the big omnibus boy, because it's a big one.
Yeah, and a couple words about the 50 state strategy to kind of set us up for
Yeah,
when, right?
absolutely.
And just to say that for the folks in the room here, please use your raise hand function if you are going to be asking a question rather than just jumping in because it can be disruptive. So please just let Edwuan, finish his point and then he'll get to your question, right? So that
Well,
little
I'm saying I'm thankful I can see Barbara in my boxes here.
yeah, yeah.
Let
No,
me see if I can.
I just want to respect your space and how you're presenting here, so as well
Oh,
as to
no
get
problem.
through
I
questions.
appreciate that.
Okay,
I
cool.
definitely appreciate that.
Okay,
Let's see.
go for it. You're doing a great job. Thank you.
No problem at all. So let me see here. Rolling us back through. So just the duties of DMAS. And I do need to change the section 4 because Steven's gonna kick my butt for that. But so duties of DMAS is, which is the Department of Medical Assistance Services as one of the key figures of Medicaid right now. They have the biggest haul of work to do on the first end of things. Okay. So they have to develop a phased implementation plan to convert all of Virginia's current multi-payer system into an integrated public financing structure. Big things to do there. We have to do the conducting of fiscal projections for at least 5 years, ensuring some actual soundness to prevent unintended consequences, such as cost shifting to localities or employers. Okay, that's another way to mitigate this thing. Because that's something that's actually come up in having some of these conversations where people are like, well, what's going to happen if the locality's got to take on burden for the Department of Health, or what happens if an employer takes away from all of that? This also identifies opportunities to consolidate all of the administrative functions across all of the state departments and the federal departments overall. And then advisory committees to be established representing providers, hospitals, unions, businesses, patients, local governments, things that we don't have right now. And last but not least, honestly, to submit annual reports. I want to see a report every year. The governor and the General Assembly have to see a report at the end of the fiscal year detailing progress, cost analysis, where our waiver status currently is, and any stakeholder feedback that may come up in that process. So we've had this discussion with Steve Kimball going into the federal funding waiving strategy. With where certain states have to go in the beginning, you may need the waiver to do it. Okay, you may need every single waiver that is available to you from the federal government. However, when you move into a state-based universal health care situation where you're actually sure, there is one particular waiver that you will no longer need. Okay. Let me see and I think I've got that one in there as well. Let's see. Yeah, here it is. So these are your 4 waivers that you would give. This is every single solitary year, your state goes and get these 4 waivers from the federal government. The 1115 waiver to consolidate all your Medicaid and CHIP funding. The Section 1332 waiver for federal premium tax credits and cost sharing reduction. Your Medicare demonstration authority, which is to evaluate integrating your Medicare financing. And if federal approval isn't granted, you actually have the CCFA, which is the Cardinal Care for All, that will serve as a secondary payer. And so even when you've got inroads with the federal government, right, where you're trying to have, when you end up having that clash and that fight, there's still, what's the word I'm looking for? There's still a remedy in place. There's still a way to get the job done, right? And I was like, Mike, is your hand up or are you just holding your head? Okay, he's just holding his head. Cool. And then of course the last waiver is that coordination with the Veteran Affairs and TRICARE and the FEHB, and just to ensure that the Cardinal Care for All wraps around rather than replaces those federal benefits. We just want to wrap around them. We don't want to get rid of them because they already do a pretty good job as it is. We just want to make sure whatever they don't have, we can cover. The waiver that I was talking about that you may need it now and you may not need it later. is the 1115 waiver. Okay. That's one of the waivers that Steve really got on me about, and trying to move into a global financial system, where we're not destroying folks with fee for service the whole time. And you know that because that's the bugaboo, right? Is you get to this place where everyone's doing the fee for service situation, and so now if I go get surgery with one doctor, it's $20,000. If Barbara goes and gets the same surgery with another doctor, maybe $35,000. And so we want to get away from that and kind of streamline what the cost of those kind of things look like, which is why you want to move to a global financial model. Now, from an independent standpoint, if you're an independent practitioner, fee for service is your best friend. I understand that. I'm not going to get rid of fee for service for you. Why would I? It's your bread and your butter. It's the way you maintain your business. I don't want to ruin that for you. However, if you work in the gigantic conglomerate that we call hospitals, okay, that is where in the realm, I want to give you all of the global financial backing in the world. I want everything to be as streamlined as possible with the least amount of cost that we can muster. Okay. Because we know even in Virginia, I did some studies on that, going to look at certain hospital surgeries based on at the University of Virginia Hospital over in Charlottesville, which is about an hour away from me. It is significantly cheaper to do all of the surgeries at that hospital for me than it would be to do it right here in my own city where I'm at, and which is in Richmond. I'm in Richmond where they've got MCV, which is the medical campus of Virginia, under the Virginia Commonwealth University. If I go there, all of the same surgeries that I would get would cost me at least $7,000 to $12,000 more because I'm in the capital of the state. If I drove an hour away, it would be less. And so that's where we kind of have the issue of the global financial structure, right? Where I can drive an hour away and it'll be cheaper for me. Why not streamline that across the board so I don't have to drive an hour away? Hi, benefits and covered services. If I'm missing any, let me know. So it should cover primary preventive chronic disease care, mental health and substance abuse services, hospital emergency and maternity care, prescription drugs with negotiated pricing, which we've already started doing in Virginia. We're starting to look at see what we can do to get big pharma out of Virginia as much as we can. Get the hell on. Aetna left, y'all leave with them. Bye. Go, yeah, please. Dental, vision, hearing services, what we can do to not only just have the basic services that we have with Medicaid right now, but to expand on those services, to incentivize them to do more surgeries, to actually do real health care in that regard. Not just the basic, oh, we get to do a dental exam or a cleaning once a year. No, I want you to get your eye exam. If you got cataracts, I want you to get surgery. If you need any of those things, I want you to be able to do that. I want you to have the options and plausibilities to do that. If you want to get brand new teeth, you should be able to get brand new teeth if it comes to that. So there's that, and then diagnostic testing, and specialty care, any long-term services and support that's already been recommended by DMASC. So there are some long-term services here in Virginia that we have that are not everywhere else. So that's one of those moments where it's very Virginia specific. We have certain programs called mobile crisis and community stabilization, mental health skill building care, where folks who usually come out of incarceration are transitioning back into society. And through that process, they go through what's called mobile crisis, where they are in an immediate situation of displacement or what have you. And those are considerable as longer term services because we keep them for a longer period of time. Lode.
Yes, thank you for this. I'm looking at the maternity care, of course, as a midwife that specializes in home birth. And
Yep.
one of the issues that home birth is on the rise is because it's so dangerous for Black women, Black mothers, Black families to birth in hospitals. Would that be covered in the?
Yes, that is super. Yes,
as well?
absolutely. Absolutely. I thought about all the doulas in the universe, all the doulas, all the midwives, because I've got a couple of them in my care. I've done some advocacy legally for some of them for that exact reason. And so, yes, I absolutely 1,000% covered all the things in that regard. Caroline.
Yeah, I wonder if there's a provision for covering clinical trials if you have to travel out of state to do things like that?
So for clinical trials, that would fall under some of the recommended, like long-term services and supports recommended by DMAS. And so like situations like those kind of specialty situations, like I was talking about like with mobile crisis and things like that, because there's going to be services and things that are available that are going to be available out of state, that are going to be available elsewhere. And even within that to kind of cover those things when they're needed. Malia.
Thanks.
What about palliative care and hospice?
Oh, that's all, yeah, automatically covered. That falls under the the primary, preventative, and chronic disease care. Lode?
Yeah, so which one would the home births fall under? Would that fall under the maternity?
Maternity care. That's why I left it at maternity care.
Okay.
Yeah, I left that very extremely broad because it covers the entire realm of OBGYN, neonatal, doula, midwife. It covers all of those things. Mm-hmm. Ms.
All
Grover?
right, thank you.
Okay, keep her hand back down. Cool business. Last thing it does go into is the durable medical equipment and home-based care. We just asked about that, about hospice care. As a person who's got that kind of at the forefront of my mind, just losing my grandmother at 92, that was a big one for me. That's why I was one of the last ones. Because we did a lot of hospice, we did a lot of palliative care. And then of course the bigger thing with this too is that last statement down at the bottom, evidence-based practice standards shall guide these determinations. And so that means that this list can be changeable, folks. That means that this list can be changeable. That when we see something new, like we just talked about a clinical trial, we see certain situations come up, it can be added to this list at any given moment. Lode.
Yes, I apologize for the
You're
repetitive.
fine, you're good.
And I'm so thankful for this. And the reason why I'm asking is because these are the issues that we've run in with billing for Medicaid, with
Yeah.
home birth and most community midwives falling outside of a practice. So we do not practice with a hospital, and many of us do not have like our own brick and mortar practice. So we
Yeah.
are traveling across the state, sometimes a region, and we have mothers coming from outside of the country sometimes coming to see us. Would we also be able to utilize that home care as well? So let's say if it doesn't fall into
Absolutely.
maternity care,
Absolutely.
we can okay.
Absolutely. Absolutely.
Awesome.
And again, it goes back to the evidence-based practice standards.
Thank you.
That's a big
trying
one.
to make sure how I can.
Oh no, you
can
listen.
deliver this.
I'm here. The unintended consequences are the best conversations to have. And so that is absolutely 1,000% covered. And I say that more so because that last statement for me encompasses it all. Any evidence-based practice standards that anyone sets forth to the state. If you was to come into Virginia and say, hey, I see y'all doing this county care for all thing. Let me talk to you about what I got going on over here. Now we can add that care or add something to incorporate that within what we've got going on. And making sure that that's adjusted. We've got this this evidence-based practice that we've got going on that Lode just brought to us. How do we incorporate that into this? Chuck?
Yeah, so we have just about 10 minutes left here, Edwuan. So I wanted, if we could pivot, and my apologies for not doing a better job introducing you. I just know you so well now, and I don't know why I didn't
It's
think
okay.
that.
It's okay.
But and also you made references
we'll
to,
have more meetings as well.
You've
We'll have
also,
more
yeah,
meetings.
and what I want to do also is make sure that people know how to reach you, because you've put together a model bill here, and any number of states could probably be do like a stress test, like figure out where bills are at this particular point. So maybe making yourself available to kind of help people see this legislation.
I'll drop my email in the thread in the chat.
'Cause I think
Let's see here.
a fresh look at our legislation is always helpful, I think,
Oh
And
yeah.
the other is let's dig in just a little bit on the legislative strategy and how we're going to get this passed by 2029, right? That's our goal,
Okay.
is to get this legislation passed, assuming that we flip the power over the next few years. And then what is that going to require of our folks across the country? What do we need to do, and how we need to sync this up again with the state efforts, Yeah, so any thoughts you have on that, I think would be useful. You're dropping your chat
Absolutely.
or your contact information, which is terrific for folks to reach out. And then other folks, if you have questions related to that particular piece of the discussion about strategy, that's kind of where I spend most of my head time. Thanks so much, Edwuan. Great job so far.
No problem. And to what you're saying, Ms. Lewandowski, the state plan would not cover anyone who comes from out of the country on the covered plan. However, it would make sure that the provider is still compensated because of that.
Yeah,
That makes
and I think
sense.
there was Judy asked a question about tribal healthcare, Native Americans.
Yes, that for me, any of the current federal benefits, I've never heard of tribal health care. I'm happy to walk through that. I've never been approached about it. And
Yep,
so again, one of those moments where for me, evidence-based practice standards come in heavy here, where
right,
if something that has not come across the forefront or that's been forthwith, it allows for people who have different experiences or different backgrounds or situations like that to be able to come
right,
in
right.
and actually facilitate doing that.
Yeah, the Sabuka bill, as it's currently um, uh, drafted, carves out the VA and American Indian healthcare, so that those programs are untouched by this legislation, the Sabuka
Right.
legislation. So just understanding that piece of it and what that would mean
Yeah,
for each of the states and the state bills. That's I think where Judy was coming from. Thank you.
absolutely. Let me see. There was a couple of votes. Yeah, okay, cool. And then just to kind of roll us through, there's a few more sections here where we cover provider payment and hospital financing reform. Um, Notice that the fee for service for independent practices does have a phase out plan. Um, Section 7 covers financing and fiscal safeguards. Which I will do, but Chuck, is it okay? I want to give these at least this outline bill to everyone to see if whatever thoughts that they have or what have you to kind of go over that, and then I'll move us as quickly as I can here.
Okay.
So this is the financing and financial safeguard section. Um, Excuse me, and then the consumer protections and rights. No resident shall be denied care due to their pre-existing condition. Annual cost sharing should not exceed $30 unless required for federal alignment. And then of course the appropriation is to kind of work through and see, I put a kind of just threw a number up there. So the appropriation for whatever the process of moving things will look like, whatever that is adjustable for your state, absolutely. Put the number there. And then of course the effective date. Now I'll stop us here for just a second and move us over here to the big boy real quick. Okay. So this is the big bill. It is, let me pull up the sections page here. And on the left-hand side, you can see there are a lot of sections in here. A lot of them. This document is 35 pages. Okay. So this is where I like this is the devil in the details. And so for
Can you
all you
expand?
folks that
Can you
yeah,
expand it again,
go-
Edwin?
yeah. So can you see the document tab on the left-hand side?
Yeah, but I can't read the print. You need to
That's all
expand
right.
the.
I just wanted you to see how many there's a lot. If you can see there's a lot of sections there. That's what I was saying. So I'll move that and get to the big guy right here. So this is the actual big bill itself. It's 35 pages. If anyone wants to go and take a crack at looking through it with me, I know there's a couple of comments in here from Steve Kimball who's already looked it over. And so this is where we kind of get into some of the waiver stuff, but there's already been some comments added in here. I really want to finish trying to perfect this to the best of my ability or get as close to that as possible. So that we can try and do a trial run in Virginia. If you miss Lewandowski, it's just there's this down to 50 pages. But thinking from the sake of a 50 state based strategy, we have to be very, very mindful I know it's about to be 10 o'clock. I'm sorry, Patty. It's okay. Um, and for me, whatever this looks like to fit best in your state is what matters the most. Like, if state-based universal health care looks different in each state to dedicate to what those individual needs for its individual market or what have you, that is the best course of action so that when we have a conversation about the big federal bill, we can start navigating some of the mistakes or the things that may come up that happens in different states. I think that the biggest part of this, from a 50-state strategy, is that if we can get more states to actually dig into this, the harder it becomes for the federal government to keep telling us no. Because that's the biggest thing for me is for me as an entity that cannot take on any debt, if I can find a way to make sure that everybody in my state is covered in their individualistic situations or what have you, for the entity that can take on trillions of dollars of debt, there is no goddamn excuse in the world that you can give me on God's green earth outside of talking out of the side of your neck to tell me you can't do this. It's a choice at that point. And so I think we'll start to see, I'm hopeful, honestly, more than anything else, that for us, in the one payer state, group and for the Sabuca folks, that we can start looking at our champions, start choosing our champions in individual states to start trying to bring these things forward, at least to start with the outline and overview bill of what it looks like so you can get some critiquing of it done to your individualistic state and dedicating it to the situation. I think we're all in this for the same fight. We are. And I am thankful for every single solitary person on this call because we're in this for the same fight. And whatever it requires of me, the moment Steve sent me this is what I've been doing for the last 2 months. And so it's going to take, it's going to take a lot. It's going to take some time. I really want to start having some strategy calls once we get to the policy part of it to really start having the strategy legislatively to start talking about, all right, who we got in Michigan, who we got in New York, who we got in California, who we got in Arkansas, who we got in Kansas, who we got in Montana, North Dakota, South Dakota. Where are the legislators that are going to be willing to carry this thing forward state by state by state and actually start having these tangible conversations? Because as we know, when these conversations start to be had, eventually something gets done. Ms. Barbara.
Right.
It's Edwin, what I wanted to just add in, it is so critical that we get out and create relationships in communities that are different from ourselves, crossing
Absolutely.
those ethnic, class, and cultural boundaries. I'm
Yep.
in Ithaca, New York, and they have not wanted to do that at all. The progressives are just so stuck in their own cubicles. But I think,
Well,
go ahead.
yeah, I agree. I mean, the thing is even with the experiences that I have, hearing about certain things like the tribal care and things like that I've never experienced before. If you wouldn't have told me that today, I wouldn't have known. And I'm okay with saying that as the person who wrote this. Because guess what? That means I get to learn more now. I get to do better for you. Chuck.
Yeah, and storytelling is a wonderful way to bring people into the conversation.
Absolutely.
Okay.
I want to go Larendowski and then Chuck.
Go ahead, Catherine.
Hey, Edwuan, I just wanted to say real quick, sorry, I'm getting ready to leave, but we've had a really good tribal review done on our Washington Health Trust.
Okay.
We don't really have permission to publish it on the website or anything, but we have permission to share it with anybody working on policy. And I think
Absolutely.
that might be really helpful. I'll send that to you.
Shoot it to
okay?
me. Shoot it to me. Absolutely.
All right.
I'd say that during our Sabuca calls. I was like, if you got anything you can send me for reference, I'm happy to have it.
Right. Right. Yeah, and there was a couple of references to Jim Kahn's done a study. I was asking in the chat.
Yes,
if
at
people-
UCSF.
Right. Yeah. So let's make sure that Edwuan gets that. Feel free to copy me on that stuff as well. I also just want to say, I
Hank
know
has
that
his
we're at the
hand up.
top. I know we're at the top of the hour and folks are going to have to start cutting out, but I want you to know that Edwuan, Lode, Pat, who's with us today, are part of a larger team that includes Healthcare Now, Labor for Single Payer, any number of our single payer allies and organizations. Is that we're building a strategy this year, right, to really get out into the community. We've got meetings coming up in Philadelphia, Netroots Nation, Labor Notes in Chicago. There's an international conference, Global Resistance, in Amherst, and then we're doing an event on May 16th. Lode is helping to take the charge on this. You can maybe drop an announcement or something, Lode, where people can find out about this. But on Saturday, May 16th, from 12 to 4:30 p.m. That's a Saturday. We're going to be doing training on a lot of these topics that will help us build out strategy, understand what we're doing, and how we need to collect our efforts and build a mass movement in order to get this legislation passed. And at the end of the year, if you want to circle the date, November 14th, that is our goal, to get together all of our, all takers, all folks in the social justice world, not just healthcare, but health, which is everything else. We want to come together. That's the second Saturday after the scheduled election in the fall. So we're building out a strategy to implement this. And then remember that on Tuesday, the 14th of April, that Carrie will pick up the thread here that Edwuan has laid down in terms of discussing more deeply the 50-state strategy. So please show up if you can on that and spread the word, and then make note of the May 16th event as well. Thank you so much. Let's see, Catherine, I don't know if you're up again. Hank hasn't spoken. Why don't we go to Hank and then
Yes.
Yeah, Hank.
Good.
Go ahead, Hank.
Yes, thank you. Yep. Hello. I think I'm on. Yep. A comment and a suggestion.
Yeah.
A lot of countries use the quote market basket definition for what's covered and what's in. So again, that can change as the board or the benefits subcommittee defines things, that are evidence related, that are
Absolutely.
more, to get OB coverage in rural areas, to expand it. So in other words, services can expand and contract. And so I like the way, some bills have been written where it has a 2 to 3 page laundry list of every single thing that's covered. And that one, it makes the bill real long. And number two, that's going to change as medical science and population.
Absolutely.
So again, quote, the market basket will be of services. That's one of the phrases I use. So I'm glad you put that. So the main question is, you mentioned earlier the financing. Again, since states have to have balanced budgets and can't print money, and have a federal reserve account, et cetera. The difficulty I run into some people is, well, okay, so you promised me 20-30% savings, but that's going to take a while to roll out. What happens during the initial 1 to 3 years when you get the financing? And of course, we're not going to have an Obamacare rollout type thing. We're going to make it really simple changes, with a payment system first, and then the fee for service and et cetera comes later, et cetera. So what run into as far as what would a state do if it had a bad 1 or 2 years and had to in the transition? And how does a state find the money during the first year or two of transition?
Through the transition, you want to try your best to utilize, like my friend Pody, who's in the comments, I need to invite him on our calls, has been very exponential in helping me trying to kind of figure out what that looks like. In situations like that, especially with the first few years of transition, the biggest money pool that you're going to have is going to come from the federal government regardless. Okay. The states will have to more than likely put in anywhere from 40 to 50% to match down over time for those first 3 years to actually stay afloat. Now, if it gets to a situation where, budgeting is kind of a part of it, we've got to do a better job of budgeting. I know that that's not going to be easy in high budget states. And so in those individualistic situations, we have to find ways and find avenues in which that revenue is going to be prevalent, right? And it currently does mean a lot of times that a lot of the money that we're already using will just be shifted to do that anyway. Right, when we're talking about medical health, mental health services and things like that, all of those things are compartmentalized on the budget right now.
Right.
And so what does it look like to take all of those line items and say, all right, we're going to move all of these and then move them over in the Medicare for all?
Don't need something to work on, and I'll send you an email later. But that whole budget
for sure
is something we have to flesh out a little better over time.
I think so too. I mean, because again, for me, that's why I say, what it goes to what I said earlier about when we're talking about the individualistic state to state, everyone's situation is going to be so different. And so it's really going to be, a little harder to just try and circumnavigate just that part of it more than anything else, because every state doesn't have the same budget, right? And so we got to figure out what that looks like, because it will look better in some areas and it won't look so good in some areas.
Okay, thank you.
But I definitely, yeah, absolutely. I thank you for your time and your comment, and I look forward to seeing an email from you soon. I want to go Amy, Lode, and then Catherine.
Hi, my primary question is, when is the next meeting for this group? You said in April. And the other thing is that I'm from New York State. There's been all sorts of position papers on how the New York Health Act, which is our single payer for the state,
Yep.
will save billions of dollars. And there's position papers on that. It refers to New York State. But as a nurse who has to deal with insurance companies, I know how much they derived and how much they cost, and it was awful. And
Yes.
It's amazing. Getting insurance companies out will save us so much money.
So much money. All the money. All the money, all the money.
Administrative costs, not having to do all the checking and the balancing. But when does it? I won't be able to make it, but
It's okay.
I will tell someone else from my group.
Yeah, so it's the third Friday of every month.
Okay.
So I want to say our next one will be right after tax day, if I'm not mistaken.
So the next meeting is the second Tuesday. I think that's
second Tuesday.
That's when Carrie Ryan, and I'm typing the dates into the chat right now. I'll be done in 1 second. But yeah, the second Tuesday is Carrie Reingans, and she'll be with us on the 14th, April 14th at 5 Pacific, 8 Eastern. So we'll be getting announcements out, but I'm almost done with this.
And Amy, I live in Ithaca in New York State, and Dick Gottfried, who's retired, who
I
I've
know
worked
Dick.
with, and he is still participating in the movement. He is absolutely phenomenal.
I know,
Has
I've met
always been.
He's wonderful.
Yeah, the best. The best. Yeah. Chuck, you may even want to have Dick on.
Oh, we've had him before, but yeah, he's always welcome here. Absolutely, he shows up a lot of times. But thank you, Barbara. Let's see, we probably want to put a wrap on this at this point.
Yeah, I was going to wrap us up.
And then final comments, Edwuan, and then I did put the upcoming events in the chat. So I'll capture the chat and send it around. But on your own, everybody try to catch that as well. Thank you so much, Edwuan. Brilliant job. Thank you so much.
No problem. I will say final thoughts for me, guys. It's still a work in progress. I'm so welcoming to all of the feedback that I'm seeing, even just like, thinking of ways to try and come up with more revenue and things like that. Those are going to be big conversations as we go forward. And I look forward to moving forward with all of you together. And I hope we are able to continue to link arms and walk in lockstep.
Yep. Right. This is our goal. This is our theory of change, right? Is that we're going to get expanded and improved Medicare for all through the states. This is how Canada got there. This is how any number of countries got there. Right now, the movement is at the state level. Once we flip the script, we're going to get that enabling legislation and then provide that robust push for each of these states to have the best support possible. Edwuan, your work is brilliant. And he's made reference several times to Steve Kemble, just to make sure Steve Kemble is our policy director, as well as PNHP's policy director, Steve Kemble, Dr. Steve Kemble in Hawaii, for people who don't know him. And David, you did ask about the VA bill. David Loud, what was that? You're looking at I'm not sure. Edwuan, do you know about the VA bill? Edwuan?
The Veteran Affairs one?
David?
No, I didn't ask about that. And somebody already made the point that in the Sabuca bill and in the Medicare for All bills, there's very careful delineation of the VA and the Indian Health Service as continuing as federal programs,
Absolutely.
which you already said.
Yeah,
Beautiful.
I would say that.
Okay.
I think for me, I just have to add the tribal care to it, which I'll do that tonight. And so, that of course the overall unintended goal, of course, is to never ever remove any type. It's like taking a leg off a table; it'll fall, and so you don't want that to be the situation for folks who already are covered in a lot of regard.
And Edwin, I'm going to send to you a very good position that was drafted by the American Indian Health Commission of Washington State that was added to the Sabuka bill, explaining
Amazing.
the complications of Indian healthcare and how that fits in.
Absolutely. I love it. I love it. I love it. Well, I appreciate y'all. I thank y'all for y'all times, efforts. I look forward to more meetings in future. I look forward to moving together in this work in future. And I appreciate y'all this afternoon, this morning. Y'all have an amazing rest of your day and an amazing rest of your week.
Keep hope alive.